you for joining our podcast today. Today, I have Dr. Faria Khan, our allergy immunologist, and Alix Schnibben, Director of Quality and Ambulatory Pharmacy of NGPG, joining. Thank you for joining me today. The topic today is antimicrobial allergies. Very broad topic, and I'm really hoping we'll get some expert advice from you, Dr. Khan, and Alix from pharmacy standpoint. You share some recommendations and opportunities we have. Of course, just some background. When I looked at the CDC data, it showed that 10% of US population reports allergy to penicillins or beta-lactams, but truly that's less than 1%. And when an allergy to a beta-lactam is reported, that leads to us choosing alternative antimicrobials that may not be as good, maybe broad, increase the risk of C. diff, drug resistance, hospitalization, and cost. So what I'm hoping is that we start off with some basics first. And first we'll start with you, Dr. Khan and Alix. Same question to both of you. What can we do to obtain or improve history and documentation when it comes to antimicrobial allergies?
I think it's good to get as detailed as you can when someone reports a penicillin allergy. I would say what we see the most is someone saying, I was a kid and I had a rash. That is the vast majority of the history we get to somebody who has been labeled with a penicillin allergy. So, things like, do you remember how old you were? Do you remember? And they may not, because oftentimes they were told this because they were too young to remember. What were you told? What day did it happen? Was it after the first dose? After you discontinued it, did the rash disappear? Because again, that's the most common injury. Those things help us, kind of determine and go down a certain pathway or algorithm for testing or not testing or direct challenge. So those are important details. But I always tell everyone that you can always refer to us as well, and we can do the intense history taking and determine what the correct testing might be if they need it.
That's very helpful. Alix, what do you observe when it comes to allergy documentation?
I definitely agree with Dr. Khan. It's an opportunity to do that intensive patient interview. What I have found when doing a lot of chart dives myself and discussing with patients, the history is unknown. Their mom had told them, or their father had told them, or it upset their stomach. So there's an opportunity. We go back to this every time we have a podcast about providing that patient education support to understand that stomach ache is not an allergy, that's an intolerance. An intolerance can still be used for treatment, but helping them have supportive therapy if they have those side effects. But I think it goes back to that patient interview and creating that time, because like you said, if you can get that detailed history that Dr. Khan was talking about, you could open up a world of drugs that are available for that patient to treat their infection. Because like you said, there's so many risks when you go broader and broader, but then you may pick a drug that's not as good, or an antibiotic that's not as good for that patient's infection. And then the duration of therapy is longer, and then we end up in the hospital and trying to get IV therapy because
and maybe
we missed
more expensive as
absolutely.
More expensive antibiotic.
Yes, absolutely. So when it comes to documentation of allergy, you brought up intolerance, GI upset. What is a true allergic reaction? Can you elaborate on that?
Sure. So our typical definition of a true allergic reaction would be an IgE-mediated reaction. Now, let me take one step back. There are other non-IgE allergic reactions, and we're able to kind of assess that and figure that out. But in this particular topic, at this particular time, we're talking about IgE-mediated, which is the most common direct allergic reaction. So typically you're looking at, and I'm going to pick the top symptom that we usually see is hives. That's number one, itchy hives, which can be generalized all over the body. It can be localized. That can be associated with swelling sometimes, lip swelling, periorbital swelling. The next most common symptom involved usually is respiratory. So coughing, shortness of breath, wheezing even. So in patients who have had asthma in the past, they say they feel like their asthma is kind of, acting up. The next thing could be GI symptoms. So interesting that you said that, but you're right. Most of the time it's an intolerance, but we always kind of keep our ears open for that because you can have IgE-mediated nausea, vomiting, stomach ache, even diarrhea. And then one that really starts making us feel like, oh, this is getting serious is cardiovascular involvement. Yes. And this is where the blood pressure starts going down. So we're kind of starting from minor and segueing into more of an anaphylactic type reaction. But those are the typical things we're listening for a true allergic reaction, as opposed to standalone nausea or a stomach discomfort or headache. You know, oh, I got a headache, I have an allergy. No, that's not an allergy. So so those are the typical things.
That's very helpful. And do these Ig-mediated allergic or hypersensitivity reactions, do they always happen immediately with the first dose?
Typically, yes, within the first 30 minutes to 2 hours. So that's something else that helps us kind of, sometimes it's not clear, but if somebody does have some sort of recollection of their childhood reaction to a penicillin, it is more often the case that if it's after that first dose and it's pretty rapid and after it's discontinued, the rash or whatever it was gone within a day, those all support that, yes, this was IgE mediated. Whereas if someone says, oh, well, it started happening the 5th day in and then we stopped it and then it took 10 days for the rash to resolve, that becomes very suspect to not be a true allergic reaction. So those little details that we want to get can direct us down what we need to do.
And that's very helpful. When it comes to documentation, so under the allergy tab in the EMR, should we be even documenting those that are intolerance or just true allergies? Because that's what we see. We see a list of medications listed under allergy.
True.
And if someone is not going into the details for each one of those medications listed, then we're looking at very inferior options to treat the infection the patient has. So what's our message to the providers, nursing, anyone who is getting that history and documenting?
So within our EMR, we do have the ability to be very specific through your interview and asking the questions Dr. Khan mentions about duration. What was the reaction? You know, when did it resolve? We actually have the ability in our EMR to actually document that. Instead of always selecting allergy, you can actually select contraindication. If the person has a reason why they cannot take it, whether it be a kidney function or a provider told them that they're unable to take it due to some other condition that they may have. But also we have intolerance. And so that's an ability to acknowledge the patient, that they're telling you that they've had a poor experience with a medication before, in this case antibiotics, but you have to take it the next step further. So if you select allergy, inputting what is the allergy, what happened, we have a great comment field that you can add a little bit more information if the drop downs don't make sense for you. But then you also have the ability to acknowledge the patient, select intolerance, and add their narrative, what they say it occurs, whether it is really gives me diarrhea the entire time I take it because they were unaware to take it with food. So there's a point for education, or it gave me a really bad headache. So that way you can provide information about supportive therapy. If you need to select that first line therapy, they may have the allergy for it. In this case, a lot of people report the penicillin allergy.
I think that's very helpful.
I think that is so key. I'm glad that you mentioned that. The fact that you do have a choice to put intolerance. And I think a lot of the times timing is always a problem because you're under pressure when you're admitting somebody or whatever. And so you don't take the time to do it. And I understand that's hard, but I think that's key, very key, that we have the ability to do it and you can distinguish. And like you said, you're acknowledging that, hey, we know you have a problem with this drug, but it's not really an allergy, it's an intolerance. And that helps everybody down the line.
Definitely. I think that is so important to make sure the documentation is detailed and accurate. And yes, it can be time consuming, but it's so important to make sure that when needed, patients are getting the appropriate therapy. So another question that comes up to us often with beta-lactam allergies is cross-reactivity. I know that's a very broad topic, especially when what we see is if a patient is labeled as allergic to penicillin, often we see providers choosing quinolones or other alternatives that may not be as good or have higher risk of side effects for the infection we're treating and increased risk of C. diff. So what's your message to those to that about cross-reactivity with cephalosporins?
So this is a great question because we've just gotten a lot of updates on that based on research and just, observations. So basically, the first most important thing is beta-lactam cross-reactivity is not as big of a problem as we thought it was. So that's huge. And that has kind of changed our parameter and algorithms from the allergy standpoint. Just within the last few years, this is relatively new, so I can give you some examples. So if somebody reports a primary allergy to penicillin, we start by kind of categorizing them as, was it anaphylactic versus non-anaphylactic, verified versus not verified, meaning you're looking at a chart or an ER document that says, oh, yes, this patient had this. So, for instance, if it's a non-verified, non-anaphylactic, you can actually, like hives, for instance, that would be relatively mild. And that's actually probably the most common thing that we have. A cephalosporin can be administered without any testing or additional precaution, period. So there's that breaking that myth that, oh my gosh, it was a penicillin allergy, we've got to be careful about cephalosporin. No, it was not a big enough reaction to be that cautious about it. In the rare case that somebody actually did have anaphylaxis, you can use a non-cross-reactive cephalosporin like cefazolin. You can give that without testing. The whole idea behind beta-lactam cross-reactivity is the R1 side chain. So that's the whole issue. So there are subfamilies of cephalosporins, you already know this, that have different R1 side chains and some that are similar, some that are not. And that's where that cross-reactivity comes from. So you're okay to use a non-cross-reactive cephalosporin, even in the case of somebody having had an anaphylactic reaction or a history at least to penicillin. Now, on the flip side, if the primary allergy was a cephalosporin, it's kind of a similar thing. So if it was a non-verified, non-anaphylactic, penicillin can be given without testing. So it's the same thing on this side. For the rare history of true anaphylaxis to cephalosporin, you would do penicillin testing in a drug challenge. So that's it. It's kind of written out. But the idea, again, is it didn't used to be that we could just give it. And now we can just give it as long as it's a non-anaphylactic
I think that's
reaction.
very, very helpful to know because, again, a good alternative we can give penicillin would be cephalosporin. So I think that's very important before we jump and give quinolones or aztreonam or something else that may be inferior.
Correct.
What is the role for antibiotic challenge? When does that come in?
So depending on the algorithms that we have, for instance, even our penicillin testing, we could do a challenge at the end and just give them, and that's what we do for the complete test, 250 milligram amoxicillin challenge. So for penicillin alone, not the beta-lactam cross-reactivity, but if it was kind of a remote history and it was benign, we don't even have to do the skin test part of it. We can move directly to just giving them amoxicillin. That's also new. That's a newer thing that's fallen out recently. And so the challenge definitely has its place, whether it's linked to skin testing, if you're going down a particular pathway, depending on the history, versus it's a standalone if you're going down another pathway. So there's definitely a place for it in many instances. Another good instance, I know we're talking about beta-lactams and penicillin, but macrolide allergy, so azithromycin, or erythromycin, even though we barely use that anymore. But for those, it's incredibly rare, really rare. Of all the antibiotic classes, that's probably the number one that you really don't have a true allergy to. We don't find that statistically to be true. So for that, we do direct challenges. We don't do a whole lot of skin testing because if someone tells us that, immediately we're like, oh, don't think you probably do have an allergy to it. And funny enough, I've actually done it 2 times in my clinic fairly recently and just given them azithromycin, and they're fine. Yeah, there's no issue with it. So
thank you for sharing that. That's very helpful. One of the other aspects of allergies is that 80% of the patients who have an allergy may outgrow that in 10 years. So I think that's such an important aspect that patients have allergies recorded in their EMR and that continues for decades. So what can we do to delabel allergy? this?
It's again going to that history and asking, and you're absolutely right. Just real world experience. We see so many people that come to our clinic not for penicillin allergy, but we're very aggressive about noting it. As soon as we see it on the chart, we will ask them, even if it has nothing to do, their visit had nothing to do with that. We're like, well, wait a second, tell us about this, because we understand how important it is to delabel. And you're right. You cannot believe how many people in their 40s, 50s, and 60s are still walking around with that label on their chart, and they had the reaction when they were 5 or 3 years old. And so we delve into it. We ask all the questions that we were talking about. And, nowadays, again, it's remote, it's benign, so we don't even have to do the skin testing. We just say, hey, come back. We'll give you some amoxicillin. And you're right. A vast majority of people within 10 years of that reaction. So if it was 5, they would have been over it by the time they're 15. And I'll say that it's not really necessarily a growing out of, but it's a shifting of the things on somebody's custom allergy list. That penicillin tends to be one that drops off the list. But it's that's kind of how we look at it.
Okay, that's great. So what do we do currently, Alix? Do we do anything to delabel patients, or is the recommendation that if a provider wants to delabel a patient's allergy, they have to refer to allergy evaluation? What is the process now in the outpatient?
In the outpatient, we rely a lot on our experts with our asthma and allergy team, that we have that great opportunity to refer within our community to get that prompt response to delabel a patient. But more and more providers, as more information is coming out about how patients can outgrow allergies, I think more people are willing to try a penicillin, especially if it's been 30, 40 years, because we can all see that wanes, especially going to peanuts now. We're seeing more and more people with such a severe allergy that's well known in the community, and people are more terrified of the reaction and what can happen, that they're seeing more and more data about peanuts and what we have available for that, which is leading more providers to feel comfortable to conquer the antibiotic questions. And if they feel comfortable, go ahead and try it. Because a lot of patients are like, I don't know anything about it. I'm willing to try it. And so, you tell the patient what to look out for, who to call, what other resources are. So we're starting to see an increase of that for patients and delabeling them, but more confidence when they refer to the expert to do that testing and have the conversation.
I think that is so important. I think that's one of the most important messages I hope our providers community gets out of the podcast is about delabeling allergies, because otherwise, again, we keep choosing alternatives. A question I asked Dr. Khan earlier, but again, for the sake of the podcast, I'm going to repeat that, is children with viral illnesses, when they get amoxicillin, sometimes get a rash. And then they're labeled as having penicillin allergy for the rest of their lives. What can we do there to really see if that's true allergy or not?
That's a tricky one for sure, because the rash can be kind of in a gray area. We're not sure if it's allergy or if it's just that common, thing that happens with kids that are given amoxicillin or ampicillin. I guess that's another way you can get that rash. So we can, again, we can evaluate and decide what to do about that.
So the best, safest thing would be, if in doubt, refer to allergy immunologists, so you guys can test and make sure that tell us more about the testing, allergy testing.
Sure. So, it's interesting that you bring that up, because I think that is another myth with general providers who don't have allergy training, is that we just have a test for everything. And we don't. We don't. We do have the great test for penicillin allergy. That one is incredibly good, incredibly accurate. But we don't have a whole lot of standardized tests for a lot of other drugs. And so therefore, as in your other question, we do a lot of challenges because we just don't have validated standardized skin testing for it. So the challenge definitely is important. Skin testing is much more relevant for penicillin. For cephalosporin allergy, we could do a skin test if it was a more serious reaction. We could do it to kind of a parenteral cephalosporin and then follow it up by a challenge. So it kind of mirrors what we would do in a more serious penicillin allergy reaction. But past that, there's not a whole lot of skin testing. There's more challenging for things that we don't have skin testing available for. For instance, the azithromycin that I was just talking about, there's really no skin test for that. But again, the history is suspect inherently based on statistical probability of there actually being a problem with that. So
okay, I think that's very, very helpful. I think so. We don't do any allergy testing in patients. So from what I'm hearing, it's primarily here, at least in our community, done in the outpatient setting.
correct.
I know there's some stewardship programs that do have that for inpatients. Maybe that's something for us in the future to work towards for inpatients. But currently, I think most important thing is to make sure that when in doubt, always, I think, go to the experts, seek advice from our allergies team, and then you mentioned about the macrolide allergies and quinolones. Another common question we get is quinolones cross-reactivity. If ciprofloxacin is reported as an allergy, can I give levofloxacin or moxifloxacin?
You could do it. We can do challenges, oral challenges for that. The thing which we had discussed a little bit earlier is sometimes a fluoroquinolone reaction will be a direct mast cell degranulation through a certain receptor on the surface of the mast cell. So it's difficult to tell whether it's a true allergy or just a direct mast cell degranulation, but either way, it can be a fairly serious reaction. So again, it depends on the risk stratification and the history. Was it anaphylactic? Was it non-anaphylactic? If it wasn't anaphylactic, you can use a different fluoroquinolone without skin testing. You can challenge to that at least. If it was anaphylactic, we would have to be much more cautious about it, obviously.
Yes, definitely.
But yeah, if it was non-anaphylactic, like a rash or something like that, we could try a different fluoroquinolone, or at least challenge to it.
Yeah, I think that's very helpful. Anything you like to share, Alix, from what we observe commonly or barriers in terms of barriers to document to good allergy history or delabel, any barriers that we see outpatient?
I think the greatest barrier is time. So with the way that the healthcare system is designed now, it's getting the patient through and not so much focusing on the quality of the interaction. So making the time, as Dr. Khan said, to take the opportunity to gather that history, but also provide the education to the patient. The other thing I think about the barrier is we think about resources, talking about ask our experts. There's great tertiary resources. So, LexiComp is a great one, talking about cross-reactivity. We don't expect everybody to memorize those things. We're not all walking encyclopedias like Dr. Khan is right now and myself when it comes to that cross-reactivity and the side chains. So that's where using something like LexiComp, putting in the patient's allergy, putting in what you want to prescribe, and then getting a quick feedback about, can you do this or not? What is the percent risk, and what are some things that you can do to prevent or provide education to the patient to be comfortable to identify the reaction, and what are the steps they can take at home to treat the reaction before they get to the next level of care or when to contact their provider. I think it's utilizing resources but creating that time to have the interview. So we talked about how the hospital can help outpatient. One of the things is you guys have the time. The patient is a captive audience that can't escape and it doesn't have another appointment. So taking that time to partner with our hospital providers to take that detailed history or have the inpatient pharmacist come in and really dig a little deeper into that. And, I come from an organization where that was a pharmacist ran penicillin prick service line. And we did that all the time. Our inpatient pharmacist did, and we learned a lot, published a lot on it, and we were able to increase the utilization of first-line antibiotics within the entity I was at. So I think it's using resources, expanding services, and making the time to take care of the patient will definitely decrease that resistance. We're all worried about the cost, the emerging problem of C. diff that we're starting to see in our community. I think that is one thing that we can do is those three things to really focus on cost, access, and then reduction in C. diff.
I think that's very important. Thank you for bringing up pharmacy-led programs because I feel even in our ambulatory setting, not just inpatient, I think we have a great ambulatory pharmacy team, and using our resources actually to get into some of these details and see what we can do to document, properly refer to our allergist for allergy history documentation. Delabeling is so important. One of the things we do in the hospital setting in the last several years, actually, with the growing evidence that the cross-reactivity with cephalosporins, carbapenems is less than 1% or so, we've been really promoting that instead of going for quinolones or Astrianam, which would be inferior alternatives. We also have an order set we've built for antimicrobial challenge. When sometimes we do see where patients are very nervous, they're being told they're allergic, and when we talk to them about maybe giving a cephalosporin, and they've been told as a child they're allergic to penicillin, and even after detailed conversation, even though, as you shared, truly they don't need a challenge, you can just give the dose. But we do have that option when we want to use a challenge, where we give this gradually incremental doses. And the order set does have medications like the Solumedrol, the Epi, the Benadryl, in case there is a reaction. So there is that option as well. Didn't talk about desensitization. The one that comes to my mind is really pregnant patient with syphilis, where penicillin desensitization. I know that's come up recently as well.
Yes.
Can you share some information about that? Is that if we do desensitize, is that permanent? Is that temporary just for that?
It's temporary just for the moment. But yeah, it's funny that you ask, because I was thinking to myself, when's the last time I did a penicillin desensitization? And it was in the hospital during fellowship. And it was actually it was a HIV/AIDS patient. So when I trained, that was much bigger of a problem at the time, because it tells you how old I am. But this was a person with syphilis, and of course it was penicillin, but penicillin allergy, which sounded real. So we did the desensitization. The important thing about desensitization, theoretically, is you're kind of gradually allowing that reaction to happen step by step so that it's controlled. And so when you finally get to that high point, everything has already degranulated, everything's out there, and the patient's perfectly stable and steady. But then you must continue dosing until you're finished with the course to keep them desensitized. But after that, it's temporary. It can come right back. And another interesting thing that's different is usually when we test, we, no antihistamines, nothing, because we want to see what happens. But for desensitization, sure, you can give antihistamines to lessen the reaction, because your priority is getting them through the course, not, is there a reaction or not. So there is a little bit of that.
I think before even we kind of start the desensitization, I think this particular scenario, at least we had recently, was someone who had a confirmed allergy from testing. Had already seen an allergist.
Yes, that is interesting.
And again, pregnant and syphilis. So the first question when we got that request was, is it true allergy?
Right.
Do we really?
But it was.
But it was. It was a confirmed allergy. So then the next step was desensitization. So always ICU setting, hospitalization with close monitoring.
Yes.
And for this particular scenario that came up, the recommendation was that the patient would be admitted to critical care. OB would be also on the consult. Team monitoring the baby.
So ready to go.
Ready to go. In anything happens.
Right.
Of course, with input from allergist, and you helped us to review that protocol. And so again, we didn't have to do that here, but just something if it does come up again. We did come up with a process how to do that. We didn't really touch on sulfa allergy. That's the other one that's so common.
Yes, it is. It is. Let me see if I have, while I'm looking at that information, just a little note on carbapenem. So carbapenem now, even if the person did have a history of penicillin or cephalosporin allergy, even if it was anaphylactic, you can give them carbapenem without any issues. Same with Astrianum, except for ceftazidime, because they have the exact same R1 side chain. So that one is the one. Another interesting little tidbit is with penicillin allergy, Zosyn or Piptazo, that one can have its very own IgE-mediated allergy. That's really interesting. Yeah. So you would think that, okay, piperacillin, tazobactam, this person had a reaction to, so we're just going to do the penicillin test. No, actually no. Their penicillin test can be negative, their challenge can be negative, and they can still be allergic because there's something else in the molecular structure that is acting as the antigen. So that is an interesting little tidbit because I was funny enough.
Interesting.
I don't have a whole lot of direct contact with internal medicine anymore, except our residents. And so I have a senior resident, and I'm like, do you guys still use Zosyn? And he's like, oh, yeah. And I'm like, oh, well, this is something to know. So with sulfa, coming back to that, so basically, if it's a benign skin reaction like hives again, or even like a morbilliform drug rash, if it's been over 5 years ago, meaning the history was 5 years ago, you can do a one-step challenge with Bactrim. So bringing in the drug challenge again, no skin testing because there isn't any. If it was less than 5 years, you can do a two-step challenge with Bactrim. So that's kind of where we are with sulfa.
Okay, I think that's very, very helpful to know. Yes. I think this has been such helpful discussion, really, because allergy is a very important topic, and we run into this all the time, every day. And anything that we can do to improve documentation, to delabel our patients who are not truly allergic or who have kind of, I'm going to use the outgrown word, outgrown it past the 10 years. That's not really the predominant, the process behind it.
I understand.
So I think it's so important. Anything else that we're not really touched on that you would like to share?
I think we've touched on everything. I think it was a great discussion, a lot of good points. Thank you for these wonderful questions. I think the main thing I just want to throw out there again is that we are here. We are here. We are ready to help. We do this day in and day out. This is just old hat to us. So we see all kinds of people coming in with, reactions to this and that. They want to know. And then, as I mentioned before, we're very aggressive about if we see it, we're going to pick up on, whatever allergy and whether it's real or not. Please send any questions, call us. We are available to help. That's what we're here for. So
thank you. Thank you so much. One last question, and then we'll go to our final words. We primarily discuss the IgE mediated, but there are other reactions, the delayed reactions. There's so many other different types of reactions too. Anything you want to share about that? Because once that's documented or that's reported, is that a kind of a final? You don't challenge, you don't
It's like
test.
a wall.
Yeah. That's kind of what I'm going with.
No, that is actually great. I'm glad that you brought that up. So one particular example that I do have information on is the severe cutaneous adverse drug reaction, like Stevens-Johnson, toxic epidermal necrolysis stress, and then acute generalized eczematous pustulosis. That's a tongue twister always for me. But basically, these are these horrible, serious skin reactions. And just a quick update on that as well, which I found interesting myself when I was looking at this information. So we think that these are also possibly based on the R1 side chain, but the data is incomplete. So it is a wall. So basically, if you have a patient who you really believe it was due to a beta-lactam antibiotic, and you really think that that's really the only thing that we can pinpoint, we do say avoid it all. That's it. Okay. So there is an example of the wall with these severe cutaneous reactions if you think that it came from a beta-lactam.
And when we say avoid it all, if it's a penicillin, avoid all beta-lactams.
So that is the one, kind of exception to, no, we can test for this and test for that. And then specifically with delayed, as you asked, that is a tricky one for sure, because I've had, I've practiced for 17, 18 years. I had one person, luckily this is not very common, outpatient at least, ambulatory, but I had one young patient who we did penicillin testing. She was negative. And then about 5 days later, she called with this horrible rash, and that was actually her history previous. And so we said, oh, goodness, and we had physically delabeled her from Epic. We had taken it off and everything, and we had to put it back on and say, okay, you actually have a delayed reaction. Rare, But here you are demonstrating it, and we have to delabel. Or not delabel, we have to relabel.
Relabel, yes.
We have to relabel. So that's a thing. And honestly, I don't think we have a tremendous amount of data on the delayed and the non-IgE.
Yeah.
So it's a little bit more murky.
Okay.
Yeah.
But what do we do then if it's allergy? A delayed reaction is to penicillins. Can we use cephalosporins?
You know, the data is not
Yeah.
complete. That's a great question. We don't know. It's a little bit of a gray area for sure. Yeah.
Okay.
I don't know what I would suggest. We could potentially, just kind of cowboying it, so to speak. We could try a cephalosporin with a different R1 side chain and just see, do a challenge or something like that.
Maybe
and
that would be where we would do a challenge.
Exactly.
And usually when
Exactly.
I do challenges, usually I do it more like informed consent with the patient. If the patient can give consent to the family for those type of situations,
Correct.
but it's on a case-by-case basis.
Totally. Yes.
So I think we covered kind of the most important points we wanted to discuss. Anything, Alix, you want to add?
Nothing. I think we've covered it all.
Yes,
I've learned some new things
I learned
myself
a lot
today with Dr.
Yes, I learned a lot. Thank you so
You're
much.
welcome. You're welcome.
Thank you so much for joining. And I think if anything, final words, each of us. We'll start with you, Alix.
My final words would be to make sure you take the time to do your patient interview. That is imperative. Use your resources, whether it's a drug reference or a physical specialist that you have a conversation with, and taking the time to actually look at what you're treating and slow down and make your selection. I think everybody's trying to do everything so quick that we're missing the opportunity to dive a little bit deeper to select the most specific antibiotic and when a patient has allergies.
Yeah. Dr. Khan?
I guess we're here. Allergies here. Refer to us. Call us. Instant message or direct message. Yeah, we're happy to help.
Thank you. And again, this has been a great discussion. I've learned a lot about allergy, and I think most important thing again is take the time to get detailed history and ensure that proper history documentation is there, and also don't forget about delabeling patients that are not allergic anymore. Thank you for joining us for this podcast. Thank you.
Thank you.